Good afternoon all. Evaluation of anterior segment parameters in relation to endothelial cell change post-phakic IOL surgery. As we know, phakic IOLs are used in the correction of moderate to high myopia as a primary mode of surgery or in patients unsuitable for corneal refractive procedures. It offers several advantages like reversibility, preservation of accommodation, and it has a minimal effect on the cornea. But since it is an intraocular procedure, regular monitoring of endothelial cell health becomes necessary. Aims and objectives are to evaluate the relationship between endothelial cell loss after 1 month of phakic IOL surgery with respect to preoperative AC duct, hexagonality, coefficient of variation, pachymetry, white to white, and post-op vault. AC duct is the distance between corneal endothelium and anterior lens capsule measured using topography, and post-op cell loss is compared with pre-op AC duct. Vault height is the space between the ICL and the natural lens measured using ASOCT, and post-op cell loss is compared with post-op vault height. White to white diameter is the horizontal distance between the outer edges of the limbus, which is used to determine the correct size of the lens, and white to white is also compared with endothelial cell loss. Another objective is to compare pre-op and post-op endothelial cell density, hexagonality, coefficient of variation, and pachymetry. Endothelial cell monitoring is very important as these cells do not regenerate, and hexagonality analysis examines the geometric regularity of the endothelial cells. Coefficient of variation measures the size variability among the endothelial cells, with lower values indicating more uniform cell sizes and better endothelial cell health. And pachy measurements indicate subclinical corneal edema, even though the counts may be normal. The patients aged 20 to 35 years who underwent ICL implantation within the past 1 year, whose complete records are available, are included in the study. And since only young patients after exclusive screening are selected for phakic IOL implantation, the only exclusion is those with poor quality imaging data. Coming to materials and methods, 15 eyes of 9 patients who underwent phakic IOL surgery by a single surgeon using phakic IOL star ICL V4C central flow were analyzed retrospectively. Pre-op AC depth is divided into 3 categories: less than or equal to 3, 3.1 to 3.5, and more than 3.5 millimeter. Vault height is divided into 3 categories: less than 250, 250 to 750, and more than 750 microns. Statistical analysis were performed using Jamovi software and paired t-test used for analysis. Coming to results and discussion, mean age of the study population was 25 years, which aligns with the typical demography for phakic IOL candidates, and AC depth averaged 3.3 millimeter, representing adequate depth for ICL implantation. White to white measurements were relatively consistent at 11.6 millimeter, suggesting appropriate corneal sizing for lens selection, and the spherical equivalent was notably high at 9.3 diopters, reflecting the severe myopic population typical for phakic IOL candidates. Pre-op AC endothelial cell density averaged 2858 cells per millimeter square, while post-operative showed 2833 cells per millimeter square. There was a net decrease in endothelial cell density, and the significance was borderline. Different studies over a period of 1 to 5 years reported an average endothelial cell loss of 4 to 13%, which was much higher than our study. This is because the IOL attrition of cells is more than the natural attrition of cells over a longer duration of time. Pre-op coefficient of variation was 33.8, improving slightly to 33% post-operatively. Stable CV suggests that surgery did not induce significant polymagatism in the corneal endothelium. Pre-op hexagonality averaged 53.4%, decreasing slightly to 52.4% post-operatively. The difference showed no significance, suggesting that the surgery did not significantly alter the morphology of the endothelial cells. This finding is consistent with Dors et al. Study, which reported stable hexagonality values with no significant changes observed even at extended period of time. Pachymetry measurements showed a slight increase from 530 to 534 microns postoperatively. This small increase in corneal thickness could represent subtle corneal edema following surgery. This shows proper functioning of sodium-potassium pump, and pachymetry is the only functional parameter of endothelial cell health, while others were morphological parameters. Another important parameter analyzed was AC depth. 60% had intermediate AC depth values between 3.1 to 3.5 millimeter, which represents the optimal range for ICL implantation. Interestingly, we found that more endothelial cell loss in the group having more AC depth, but we expected shallower chambers might predispose to greater cell loss as given by previous studies. But our study fails to demonstrate this correlation, showing endothelial cell loss does not depend on shallowness of AC. Post-op vault measurements averaged 396 microns, indicating appropriate lens positioning with adequate clearance from the crystalline lens. All patients were in the normal range of vault height between 250 and 750 microns, and this subset has no significant correlation with endothelial cell loss. The correlation analysis between endothelial cell loss and parameters like age, white to white, spherical equivalent revealed non-significant associations. To conclude, the present study demonstrates that phakic-IOL surgery results in only modest endothelial cell loss within the first month postoperatively, though the clinical significance is almost nil. There was no significant correlation of endothelial cell loss with age or other measurable parameters like AC depth, post-op vault, and white to white. The preservation of endothelial morphological parameters suggests endothelium maintains functional integrity after the procedure. While the short-term endothelial safety profile appears acceptable, careful long-term monitoring to ensure continued endothelial cell health is necessary. The limitations of the study were small sample size, short follow-up period, and the retrospective design of the study, which necessitate larger prospective investigations with extended observation periods to definitely establish the safety profile of phakic-IOL surgery. These are my references. Thank you.
Thank you, Vaishnavi. That's a good paper. Why did you have a follow-up of just 1 month? I mean, you've taken, I know it's a retrospective study, but post 1 month, you never go back and look at all of these parameters at all? Why was your, because you start entire study is just 1 month. What is the longest follow-up of your patients post ICL?
6 months.
No, I'm saying the longest follow-up you have of your, any of your patients after an ICL is only 6 months?
No more than.
Yeah, so then it gives to reason that all of these problems are more as the ICL is in the eye for a longer time, isn't it? So any specific reason why you've taken only 1 month? No, just educate me. I'm asking you, if things have not worsened in 1 month, is it that they will remain stable over the next few years? Is it so? Or you just did it for 1 month?
No, I just did it for 1 month.
Okay, so the other thing is, do you have a correlation with the degree of myopia that you could have, it's a good study. You could have done a multivariate analysis. You could have done a lot of statistical analysis on the parameters that you have, because you just presented a descriptive analysis. You have a large number. Even there, you could divide into the duration of ICL, post ICL. You could the degree of myopia. A lot of things could have been done, right?
It almost appears like a cross-sectional rather than a longitudinal. It is a longitudinal which makes a sense in such study, frankly speaking.
Because the results which you have got are just 0.9% endothelial loss compared to 4 to 13%. Was that comparison of those studies also limited to 1 month follow-up period?
No, that was 6 months.
So you cannot compare. You cannot compare 1 month follow-up where you showed only 0.9%, because it's only over course of time, like in longitudinal study, you will find more endothelial cell loss. Maybe then your endothelial cell loss is comparable to the other published studies. You cannot compare 1 month study with longer follow-up period. And how do you explain that the anterior chamber depth had no correlation with the endothelial cell loss? You showed higher endothelial cell loss in AC depth more than 3.2 or 3.5 millimeter compared to shallower AC. How do you explain that? Because that is that variance with the published literature.
Maybe due to small sample size and shorter follow-up period of study.
Because in your inference, you said AC depth has no correlation with the endothelial cell loss. So you cannot, just 1 month study, you cannot say that.